their support at the local level and at the system level. So next slide. In 2015, one of the things that Sutter did to help bridge the gap of all of these separate counties and at that time regions was to develop the Office of Patient Experience. And the Office of Patient Experience has really been established to improve the patient experience, but also to help us look from a very global view. How do we connect our separate systems and affiliates and the work that's going across the organization to create a seamless, humanized patient experience? So in the Office of Patient Experience, we have different key players that represent research, pharmacy, mental health, quality, safety, leadership development, and then, of course, our patient family engagement team, which Morgan and I represent. So next slide.
Sutter Health.
And I'll take it from here. So just want to touch on our vision for PFACs at Sutter Health. So in February 2016, as Roberta mentioned, we set a vision and a project charter for spreading patient family advisory councils across Sutter Health. And our goal really from the system level, as part of the Office of Patient Experience, was not to force or mandate that PFACs are created. Our goal was really to provide the ability for local affiliates to create PFACs in a way that would work for them, but that would also be standard and easy as possible for them to implement. So really the work of our department since February 2016 has been to create these opportunities and support the ongoing growth and development of the PFACs at both a local and a system level. And so over the next few slides, we're just going to share about some of this process, how we actually went about doing that. And so as you can see here, the first bullet, our goal was to provide ability at all levels of the organization to work in partnership with patient family advisors. In order to do that, we wanted to be able to make sure that each healthcare setting, whether it was a clinic or a hospital, would have the opportunity to establish a PFAC. And then the reason behind that is that we really believe that patient family advisors, in sharing their stories and their experiences, perspectives, help us to see what we can't see and ensure continuous improvement. Next slide. And you can keep going, one more. So this is the process, and really just wanted to call out the fact that we've really been in partnership with Patient Family Center Care Partners and Libby and Lindsay and her whole team. So yeah, in all of our efforts, we've been lucky enough to be guided by them. And for those of you who have been through this Gateways process or program, you'll know that this is a 5-step process to create, to really thoughtfully prepare and create a patient family advisory council in your organization. So we took this model, and not only have we taken on all of the affiliates that have created patient family advisory council since February 2016 through this Gateways process, but we have also used this methodology and applied it to our work in the system office here in Office of Patient Experience. Next slide, please. So yes, you'll notice that first gateway was setting the table. And in the first gateway, setting the table, we learn to set a vision, work on your charter, and start communicating out to your organization what you're going to be doing. So from a system perspective, we laid the groundwork and we communicated our vision in a number of ways. You'll see we created a project charter and scope. And we not only just created that in our team, but we actually had to communicate that and get buy-in from leadership. So part of Roberta's role as the director was going to different high-level meetings, including a meeting with our CEO, and getting buy-in from the top. And then moving from there, we were able to get buy-in from hospital administrators, managers at different hospitals. So it was a concerted effort in really getting out there, hitting the pavement, conference calls. We did a lot of WebEx, showing what we're going to be doing, and also a lot of site visits and actually sharing with people, this is our vision, this is what we're going to be doing. So that was part of that, setting the table. Another part of that was creating a collaborative site. And you'll see at the very top right, we have a little snapshot. And we created this, developed this site basically in order to house all of the tools and process documents and everything that people would need when they're creating a patient family advisory council. And that's kind of an ongoing thing as well. But that was really key that we had a central place that people could go to for the Sutter Health PFACs. And as well, we also created a detailed communication plan. I think it was about 4 or 5 pages long, and we were able to have a communications person help us out with that piece in the beginning. And that was great because it identified, who that we needed to communicate with internally, externally, and how we were going to communicate that. So that was a fair amount, I would say, of project planning, and all this planning did probably take a few months, but it was really important to set the table so that we were really clear on what we wanted to do and what our plans were going forward. And it also helped us to garner leadership support and started recruiting people across the organization who wanted to start a council at their site. So next slide, please. Yeah, recruitment. So recruitment is the second gateway. And one of our key phrases that Roberta and I say to each other a lot is that we want to cast a broad net. And we didn't make that up. We got that from Libby and the Gateways program. So that kind of has been our motto at the system level of how we can help our local affiliates with recruitment efforts. So from that system level, there have been a lot of ways which we were able to do that. First of all, we were able to create an external website. We were able to work with our communications and marketing and different affiliates to help create local press releases. You can see here's a press release on the very left. So we're kind of able to work with them so that not each individual hospital has to create a new press release. They can kind of adapt it and customize it to their site. We also worked with the My Health Online portal. So this is the Sutter Health portal for patients, where they can go in and check their medical records and email their doctor and lab results, that kind of thing for Sutter. And so we were able to get a ad put on their actual website. And we also have had ads in the newsletters they send out electronically, and that has been really helpful because we were either able to send it out to all Sutter Health patients on My Health Online, or we can also target certain areas geographically. And as you can see, just alone in 1 month last year when we had an ad up, we had over 200 referrals that came in through our website because they saw this ad on My Health Online. So that's one of the kind of great things we can do at a system level in order to support affiliates. And then we also have gone out into the community and done some presentations, and that's kind of helped us practice in a way. How do we describe what patient family advisors do in a way that's really going to resonate with just your average person who isn't in this healthcare speak? Using terms like patient family engagement to the average person isn't really helpful. So we were able to figure out, how are we going to communicate what we're doing to the general public? So that was part of that, and then also just getting out there, and we were able to recruit a lot of people from that. And we've also been doing some social media, which we were hoping to expand in the future. Next slide. So part of what we've been doing as well is for each gateways and each section of the gateways, we've been creating standard tools and suggested workflows for our affiliates to use. The one on the left here you'll see is our workflow for recruitment. And it starts from, someone seeing a flyer or, an ad on My Health Online, and the process that we are recommending to all of our councils to use in order to recruit people. But it's not just just the flow chart that you have to follow. We also created, for each step in this workflow, each bubble here, there's a corresponding template or tool that the affiliates can use. And we also leverage our website for people submitting referrals, but we also use this website for current patient family advisors so they can log their hours, and Roberta's going to talk about that a little bit later too. but just want to touch up that for all of the gateways, whether it's recruitment, setting the table, all of those pieces were on that collaborative side that I showed earlier. Next slide. Orientation. So orientation is the next gateway. And for that, because we're a large organization and we're spread out, there was some variation in how our hospitals and clinics onboard their current volunteers. So for those of you who aren't familiar, patient-family advisors are usually volunteers, and that's how we're doing it at Sutter. And basically, some hospitals had a basic, everyone has to get a TB test, a flu shot, background check. But other hospitals had a more stringent background check they wanted people to do, or a few more requirements. So what our policy then was from the Office of Patient Experience was that we want you to onboard your patient-family advisors like you do for your standard volunteers that come into the organization, but their orientation is going to be a little bit different. And so for the orientation, we also created customizable templates like we did for recruitment. And I actually didn't mention for recruitment, for all those steps, including interview questions for patient-family advisors, brochures, the how to rate, or not rate, but evaluate whether someone is going to be a patient-family advisor, whether they're good fits for the role. All those templates were included with that. And so for the orientation, the two kind of big pieces that we created for this were the orientation slides, and those are customizable slides based on the methodology that Libby lays out in the orientation gateway, and also the handbook, which you see a picture of here. And in the handbook, there's a lot of information for new patient-family advisors. It is also customizable so that people can put in the right contact information, things like that. And in part of the handbook that we created, there's an outline of, what is Sutter Health? What is our vision in general for our company? What is our vision for patient-family advisors? What are those core competencies that make a really effective patient-family advisor? And then a storytelling guide, the best way to share your stories and experiences that are going to affect your audience. And then we have housekeeping things like an acronym list that's only a few pages long. It needs to be longer probably. And also how to use VicNet, which is the tool that we have for logging their hours and looking at their schedule. And then as well, for orientation, of course, we have them sign a standard confidentiality agreement, photo consent form. And as well, just one other kind of tool I want to mention is that for all of these steps, we also have checklists for the staff, so that if they would like to use that, they can make sure that they're following all those steps. Next slide. So once our patient-family advisors are onboarded, we found that a key to really sustaining this work is engaging patient-family advisors in work that is meaningful to them, and in projects where staff really are appreciative of the patient-family advisors' contributions. And it's not just like a thank you for coming, thanks for your time, but just really actual tangible contributions. And this has led to better patient-family advisor retention and continued staff requesting patient-family advisors. And so that's kind of part of the work that Roberta and I have done from that system level, is going out and marketing to different groups that, patient-family advisors are here, they want to help, and they're a resource that we have for you to use. And they have a lot to contribute. And then people actually involving patient-family advisors in their projects, seeing that firsthand, the contributions. And so we're getting some kind of word of mouth spread, as well as the marketing that we've been doing. And I just want to point out a couple of things that they're involved in here. On the right, we have a patient-family advisor. He is working on a Kaizen, I believe, or one of those, lean events, value stream map, for the emergency department at Sutter Amador Hospital up in the foothills. And then on the bottom left, we have some of our patient-family advisors with staff who worked on redesigning and rewriting a brochure for families on ICU delirium. And at the top, we have our patient-family advisors who are the parents at a NICU group in Alta Bates. So through this, basically getting in there and sending our patient family advisors out, we learned a lot. And one of the things we learned is that we need to set up a process for getting patient family advisors involved in work. And because of that, we created a patient family advisory request form that staff can request, tell what kind of project or program they're working on, what they would like their patient family advisor to be doing with them, the time commitment, those kinds of things, and then we send that out to the patients, and then they can decide whether they want to do the project or not. And just a couple other projects, just examples of things that they've been doing lately are, as well as a lot of process improvement events with our lean office, our health literacy, reviewing materials that are patient-facing, communications around Medicare Advantage or My Health Online, and also quality improvement projects that range the gamut from, you know, a inbox management for a physician office to hand hygiene in a hospital. So all over the show. Next slide.
So this slide may look a little confusing because you're looking at a list of acronyms, but these acronyms that you see up on the slide represent our different hospitals or care centers. So if we start at the far left, you see existing. When Morgan and I came into the position in 2015, we discovered that there were several councils that had already been established, and this was silo work that had started in some of our independent facilities or medical foundations on their own. You know, those champions, leaders, pioneers that were starting out with a council independent of the system, but strongly engaged in local work. So we had PAMP Medical Foundation down in the Bay Area and Mills Peninsula Hospital, which is located in the South Bay, San Francisco area. We have 2 NICUs that were started because of the parents' need to help and support other parents. And then 2 other hospitals, Eden Medical Center, and Joe Connell is on the phone, one of our patient family advisors from that location, and then Sutter Lakeside Hospital. So we found out that we had these 6 existing councils. In February of 2015, when Morgan and I started, we partnered with Libby Hoy and HQI, Hospital Quality Institute. There was a grant received from California Hospital Association to start patient family advisory councils across California. So we had 8 sites. Only inpatient hospitals were allowed to participate in that program, join that first cohort. And it was in that cohort that Morgan really worked on developing the standard tools and processes. So we would whiteboard out our processes, put together tools, and then help each one of the sites as they were moving forward. Our goal was to have a standard approach to this so that as we rolled this work out across the organization, our patients were trained and oriented and onboarded in the same manner so that they could be used locally for projects or at the system level for projects. So we grew the 8 councils out of our cohort 1, and then we moved into cohort 2 in June of 2015. So we were practicing in cohort 2 the use of the tools that were developed in our first cohort. We grew in that by adding medical foundations, so clinics, our Sutter Medical Foundation, our Sutter Lakeside Ambulatory Site, and Sutter North Medical Foundation. So a workflow that's a little different in the clinic setting than it is in the inpatient. But we really felt it was important to get an idea of the cross care for our patients because they not only interface with the organization in the hospital, but certainly in the clinic setting and again, into the home environment. So in April of this year, we opened up the cohort 3. And in cohort 3, we brought in Sutter Care at Home, 2 more medical hospitals, and we brought in a specialty group, ICU Liberation, and 1 medical foundation, Sutter East Bay Medical Foundation. So, excuse me, I think I made a mistake. I said 2015. This actually started in 2016 with our 3rd cohort in 2017. So in the last year and a half, almost 2 years, we have a total of 26 councils, 1 council that will represent our patients at home, Sutter Care at Home. We have 5 medical foundations, 16 hospitals, and then 4 specialty groups. It was quite interesting, this Sutter Medical Center PEDS group. We had a physician come to us who is managing pediatric diabetic patients, and he is utilizing a support group model with his parents to help other parents manage their newly diagnosed children. And so he wanted to establish a council so he would have some continuity in the work and sustainability. And then we have a small specialty council coming up in cohort 3 around ICU stays and what can we do to help our patients in the ICU or after the ICU stay with possibly hospital-acquired delirium. So we're still working at the expansion and sustainability. And as Morgan mentioned, the request process. Creating a standard tool meant that we had to onboard and mesh our team members so that they could participate across the system. And it was kind of a fine balance, kind of like Amazon, supply and demand. We wanted to manage having enough patients on to market the deployment of the patients so that when a request came in from, let's say, a team working on end-of-life communication or open notes or labels for prescription bottles, that we could easily fill that request within 2 to 3 weeks and keep the patients balanced with the requests that were coming in. And so far we've been successful, and I think we're ready to, again, expand that recruitment net and grow a little bit further. Okay, next slide.
So in the org chart that we just showed you, at the very top, there was a purple box called the Sutter Health Patient Experience, and that actually represents a Sutter Health Patient Experience Council at a system level, and we call it SHPX. And what we did, we actually established this council as part of cohort 2. And in September 2016, we got up and running and had our first meeting. And the reason why we created a system-wide patient family advisory council with representation from all over Sutter Health was really threefold. So the first was we wanted to actually model best practices for patient family advisory councils for everyone in our organization, kind of practice what we preach, so that we're a part of it as well, as not telling people how to do councils, but actually doing it ourselves. Secondly, we wanted to fill the need for requests that were coming in from system groups. So Roberta mentioned that balance between how many patient family advisors we had and how many requests we had. Well, we were actually getting a lot of requests from all kinds of system level groups, from information technology to communication. So we realized that it was actually a need in the organization, which is really actually very positive and exciting. And so we wanted to build this council up. And then also, we needed to provide a home for some patient family advisors that were in geographic areas where there wasn't an active PFAC yet, or where there was a waiting list. So we were able to bring on people from all over the organization that we wouldn't have been able to before, and we deployed them onto all of these kinds of projects that you can see here on the screen, from multiple sclerosis on research and development to quality and safety around sepsis and ICU liberation. So we have examples from all of these different buckets. And in SHPX, we developed just the Gateways program. We did everything, all those 5 steps. We created a charter. We have goals for 2017 that we co-created with the patient family advisors. We have some of them filling a kind of a co-chair role. And we have monthly guest speakers to provide information to the advisors about the system and also provide some training. It's also a really good forum for feedback and kind of a informal focus group. So sometimes we'll have maybe a physician or a nurse from a hospital or some system group that needs to run by some information, whether it's like a brochure or a flyer, or it's a feedback on an initiative that they want to launch. They're able to kind of run that through the SHPX group as kind of an informal gathering of patients and family members from across the system, which they didn't have that before as a resource. And then finally, it's also a launching pad for deployment onto system projects. And because we are a large system, there's a lot of things that are pain points at local affiliates that we can actually work on and solve at a system level, and in all of these areas and many more. So that's been a great way to connect patient and family advisors from all over Northern California onto these big system projects. Next slide.
And before we leave that, let me just say one thing. Morgan leads and chairs this. I co-chair the meeting with her. This is our test environment. So if we want to test an idea or a process, we ran some great storytelling testing through here, and it turned out to be very valuable. We also ran a journey mapping tool that was not as valuable. So this gives us an idea and a place where we can work with a consistent group of patients to get feedback. Okay, next slide. Libby, can you move it to the next one? So sustainment, and you can move to the next slide. One of the things that we started right away as we started this work, and I'm going to just give you a little bit of history. Prior to us moving into this project in 2016, we were working in Sutter Health on the Gordon and Betty Moore Foundation grants. And that grant work really led to our work in this arena at a system level. And we learned a lot as we began that work as a foundation. One of the tools that we use up in the left-hand corner is a tool called VicNet or Volgistics. VicNet is a tool that is used by volunteer agencies. I think could somebody mute? I think we're picking up some background noise.
We are. I apologize for that. If everybody on the call could check their mute button, we're getting laughter and interference from your phone, and I'm having difficulty isolating it.
Okay, so I'll continue.
Thank you.
VicNet is a tool where our patient family advisors create a profile, and then we can put scheduled events on that tool. They can sign in and look at a calendar to see when we have needs for patient family advisors for specific projects. We can also use it for mass emailing and communication. And as a patient completes a project, they then enter the hours that they worked on that project in the VicNet tool. Then once a month, Morgan runs a report out of this, and we meet monthly with each one of those councils that you saw on the org chart. We can then make sure that they are logging all of their hours, and some of our existing councils are still working towards perfecting that. And then we can keep track of the number of patient family advisors that we have in our system that have logged into the organization. And you can see the run chart on the right where you can see where we've really grown. When we first started this work, I think we had 38 patients. We have about 156 right now. And then down in the lower left-hand side, the project events that we have. So as of June of 2017, we'd run 152 projects that had been logged into the VicNet application. And we could break those projects down by project type. So lean projects, communication projects, technology, customer service, quality. So we keep track of this on an ongoing basis so that we can share this information with our leadership groups and also promote the work that our patient family advisors are working on. Holding on to the documentation of their hours and their profile helps us keep track of, their hours of commitment, the work that they're doing, how engaged are they? Because if we find that patients are not keeping up on projects, then it's our opportunity to check in with them and find out if they are still interested in staying engaged. And we are working on thank you for participating letters if those are kind of waning away from the work or have new changes or challenges in their life. So the tool really gives us a pulse on what's going on across the entire organization. Okay, next slide. So as we got bigger and we started to expand the program, we started to look at the entire process across the organization. We had a value stream mapping session where we mapped out each one of the steps along the way. And we looked at what was our current state for onboarding new patient family advisors. And we were running about 48 days to onboard a new patient family advisor from the time they had put in their referral form. And to get that patient family advisor ready for the first project was about 78 days. So that's quite a bit of time. Our work now is to start reducing that. Our future goal is to get the patient onboarded within 33 days and then have them project ready by day 50. So we're starting to put together some processes around that and a future Kaizen to really talk about this work. But as we went through and evaluated our value stream work, we brought in patient family advisors to give us feedback. And what was amazing is that they came up with incredible ideas that we hadn't even considered. For example, one of our advisors, Bruce, said, why don't you take some of this workload off of your team and let us as advisors onboard and mentor some of the patients. So those are things that we're getting ready to put curriculum together for now so that we can better utilize our advisors for helping to support our team. Morgan and I are just two people that do this work across the entire organization. So we have to be efficient and utilize the resources that we have, and our patients are an outstanding resource to help us. Next slide. So as you start doing this work and you get bigger and bigger, you realize that you've got variation in practice and process. Because we are doing this now as a standard, it really helps us to hold on to the integrity of the program. One of the things that we found out, and a lot of it is finding out, we have a lot of buried treasure out there and processes that are going on in silos. So we found out from our patients, wow, I just went to this event on quality and safety and they gave me a bouquet of flowers and a box of chocolates and a gift card for gas. And then another patient would say, oh, I got a thank you card. So we sat down after our value stream and had a Kaizen event to look at how could we standardize recognition across the organization. And we put together a process document that we are still developing. This we anticipate going out the 1st of September, where we will recognize our patient and family advisors based on hours and projects that they're working on. And so we're putting together a guide to identify what they would receive as a nominal thank you and recognition for the work that they're doing. As we looked at this process, because we are a large organization, we reached out to our Office of General Counsel, which is our legal team. And they shared with us that there are national recognition guidelines within which we have to practice when we are recognizing our patients for the work that they're doing. So they sent back to us suggestions on gifts and nominal items that we could share with our patient family advisors. And right now we are working with a vendor that supplies these kinds of items to our organization. We're creating a web page. So once we create that web page, we'll have like a little web page and it will say, for 0 to 15 hours, you can offer this coffee mug, and it's branded with the Sutter logo and patient family advisors. And so there's 3 or 4 of those coffee mugs or water bottles you could choose from. And then when a patient gets up to a certain level of volunteer hours, let's say 150 hours, they would qualify for a t-shirt. So we've designed the t-shirt with the logos on it. And then the sites, our affiliate hospitals or councils at medical foundations, can order from these sites to provide those items for their patient and family advisors. So this way across the organization, our patients are recognized in the same manner for the same amount of work, and they are also rewarded with the same types of tools that are branded by the organization. Next slide. And I'm sure you guys might have questions. We'll leave those for at the end. We're just about done. Mileage. Okay, so this was another big one. Because you can see we are so spread out, we really encourage as much work done via WebEx, virtual meetings, or conference calls. But there are occasions when having the patient's story in the room will be phenomenal for changing the course and behaviors of our projects, especially around quality and safety. So we have some general system center locations like in Fairfield, where oftentimes our patients need to travel so that they can share their story and be a part of a work group. And what we have done to accommodate this is in the VicNet tool, we have created a field for mileage, a field for tolls, and a field for parking. So that what we will be doing as we move forward, and again, this probably will not go in until September, the site patient family council lead will run off a report on a monthly basis and turn this into our S3, which is where we do our accounts receivable and payment, and the patients will be given funding let's say reimbursement for mileage, tolls, or parking that were incurred during that time period. So we're still working out the details of this, but certainly working towards a standard approach across the entire organization and paying the patients consistently for their mileage as they accrue that, or tolls or parking. Okay, next page. So you can see in this, we're big, we have a lot of patients, we're spread out. Communication is our biggest challenge. We put together a quarterly newsletter that is posted on our webpage so that the patients can interface with that and see what we're doing. We also share that with our teams across the system and send out our quarterly newsletter. We often will feature a council and share some of the work that they are doing. On the left is our Sutter Roseville Medical Center Council and their members and some of the work that they've been participating in. And then on our last newsletter, Morgan did a great job of putting together a storytelling edition where each one of our patients shared a little bit of a story as to their medical history and why they got involved as a patient family advisor. And this was just one of those tests of change. How effectively can our patients utilize a curriculum to tell their story and put that story into words? So that was a great test, and it actually worked out really well, and we got some great stories out of that. But it's very important to continue to share and promote this work. In the first year that Morgan and I did this, we visited multiple Sutter sites to promote the work, share the work, and get them to sign up for the advisory council program. I think we put about 10,000 miles on our cars as we were out traveling around, but it was a great way to connect face-to-face with our team members across the organization. Okay, next slide. And we're coming around the home stretch. Okay, this is where the fun is. Lessons learned. What we've really tried to do with this as we move forward is share and bring the teams together. The wisdom comes from the field. It comes from the teams that are doing the work. And the more and more we open up that venue for sharing and cross-learning has been very, very helpful to us. Our patient family advisors are really our connectors. As we bring them into system projects, we find out what's going on down at Eden or what's going on over at Auburn or Amador. And it really helps us to stay a part of like a family and working together. We're growing our patient family advisors with more training sessions. We had a call about 2 weeks ago. We have patients that attend a program that we call Managing for Clinical Excellence. It is a program where staff members are selected, upcoming leaders, to participate in a program or process improvement project, and they're taught lean methodology, how to put together an A3, and in the 4 months that they're in this project, they have to show a deliverable or an improvement on a project. Those teams have to have a patient family advisor. And so as our advisors go through those training sessions, they've said to us, we want to learn more about lean. We want to learn presentation skills. We want to learn more about data. So putting our patients out there and training them, we are planning to move forward in October with a patient family advisor summit where we will be teaching them health literacy, storytelling, presentation skills, lean methodology, and integrated healing arts. And if we are successful, we've applied for a PCORI grant. We'd like to spread that out into 2018 if that goes forward and if this test is successful. One of the other lessons learned is a warm handoff. So when we get that request in for a patient family advisor, Morgan is our matchmaker. She talks with the requester to find out exactly what they're looking for. She reaches out to potential patients. And then when we find a good match, we do what's called a warm handoff. So Morgan will have both the requester and the patient family advisor on that call. She makes the handoff to make sure that it's clearly communicated to the patient when they need to be at a meeting, what dates and times are the meeting, and how they will connect as we move forward. So that's been a great lesson learned. We also do debrief and follow-up after a program or a session is completed so we can learn to make improvements. Site visits, monthly meetings, those are all part of making connections and staying involved. Sometimes we're on these monthly meetings and somebody will say something and we're like, oh no, you don't have to create that, we've got it right here. So constant reminders and letting them know that we're here to help and support them. Recruitment never ends, and that's Libby in the back of our heads over and over. Cast that wide net and keep on recruiting. So again, this is a little picture of us at a recent River Cats game in Sacramento, and we were all wearing t-shirts and out there handing brochures out, trying to recruit from the community. And most of it is really about having fun. I think that connecting with our patients, hearing their stories, and helping our organization listen and make changes based on what is at the heart of our patients' needs and concerns has really been one of the most rewarding positions I've had in the organization. So last slide is group discussion. We'll open it up in case you have any questions for us.
Roberta, thank you, and Morgan, both of you, for presenting your work over the last 18 months or so. You guys have just done a tremendous job of creating structure and maintaining a high-touch personal relationship approach to developing your advisory structure. So I really commend you for that. We have a couple of questions in chat, and then I'll invite others to chime in as well. Sonia's having some challenges in recruiting younger members. Do you have any suggestions or thoughts around that?
That right now is something we are still working on. Most of our patient family advisors are above the age of 18. We do have some pediatric patients in the diabetes program, but we have yet to really work with a high pediatric population. We do have NICU parents, which now their children are growing up, and so we have access to kind of the parent role, but we have not really recruited anyone below the age of 18 at this point. Mm-hmm. Morgan, anything else on that?
I think that with recruitment and casting a wide net, you want to make sure that you're placing your information in a variety of places. So maybe the younger millennial demographic uses more social media and might be more likely to see something on Facebook or Twitter rather than, or LinkedIn, rather than, you know, a local article. So I think that's something to think about is, okay, where are you marketing? Are you just doing it in the doctor's office or your newspaper? Because that's going to encourage older population. So I think that's one point.
That's a great point, Morgan. And I would also add that you might take a look at your community health needs assessment to look at some of your community partners, and those might be other touch points for you to get your recruitment materials out to. Terrific. We have more questions. Great. To clarify, are all advisors considered members of the PFAC and invited to attend all PFAC meetings? If so, what percentage of PFAs actually attend PFAC meetings?
We have local patient family advisory councils, and the patient family advisors are usually linked to a home council. So Joe is on the phone. So Joe's home council is Eden Medical Center, but we will often pull him into other projects or our system meetings, and we allow the patients the flexibility to kind of choose joining that system meeting on a monthly basis. And if they do, then that responsibility for their attendance is to go back to their home council and share information. So they all have a home group that they are a part of, but welcome to attend other meetings or visit other councils if they have that desire.
Mm-hmm. Great. And then a question, this comes up quite a bit. How do you differentiate between the role of the advisor and volunteers? And as a kind of an extension of that, did you cover the onboarding cost for your advisors, including the TB shots, criminal records, that sort of thing?
I can take that one, Roberta, if you want.
Okay, sure.
So the patient advisors, they do come on, you know, with following the same basically rules as the regular volunteers as far as the, you know, the TB screening, those flu shots and those things are concerned, but they have a completely different stream. So the leader of the PFAC is usually different than the volunteer department. So they come under that PFAC leader, whoever that staff member is. Then they have their own role. Each council has a roles and responsibilities document that's part of that handbook that we talked about. So they come under that umbrella. So that's part of forming that council, is that there's a charter and that there's a roles and responsibilities document. And part of that might be, okay, as for your role as a patient family advisor, you must clear our volunteer background check, but that doesn't mean they come on as the average hospital volunteer. They're still kind of in a different stream. And then the cost associated with that is covered by the local affiliate, not us.
Mm-hmm. Great, thank you so much. And yeah, I think there's a distinct role of differentiation between your hospital volunteer and your advisors. And I think you guys have really delineated that quite well. From John Santa, are any of the PFACs involved in decisions related to the patient portal and the EHR? And do the PFACs communicate concerns to Epic, for example, if there are general EMR issues for patients? So are they working with
Yes.
patient portals at all?
They are. They're working with the My Health Online. We also have patients on our InBasket, Open Notes. They are involved in some specific groups like ICU Liberation, where we may be looking at documentation changes. And they do have input. Again, it's kind of a partnership in this work. We're still working at gathering more information on how we get patient concerns into the organization and use those as process improvement projects. Mm-hmm. But oftentimes through our patient family advisors, those concerns are escalated to Morgan and I, and then we can reach out to the EMR or the IS team and provide feedback on that question or concern.
Great. That's wonderful. I know, our patient access work group is working hand in hand with the Open Notes crew to increase the adoption as well as the implementation, and kind of looking into how we can mobilize PFACs locally to increase that usage and uptake. Wonderful. Another question was, what's the difference in content and focus between the local councils and the system council that you mentioned? And how do you decide what gets discussed or addressed at each level?
Morgan, you want that one?
Yeah, I can take that. So, well, partly is every single council has their own charter, and part of that is their own reporting structure in their organization, how they're and what their goals and topics are for the year. So that's part of kind of the model that we've done, is we've provided the tools and everything that people need, but depending on what the focus is for their hospital or clinics, that is what their council will go for. So the agendas and their goals and everything, that's all for up to the affiliate. So at the system level, what we've been looking at is how do we have our own goals for 2017, which include things like really integrating patient family advisors into system-wide projects or different pilot groups or pilot projects that are happening around the system. So that's kind of how we differentiate it, is that those local councils are really focused on improvement projects at their local affiliate, whereas our system group is looking at the big picture things that will definitely affect local affiliates, but the decision making around that is not done at the local level. I hope that makes sense.
Great, thank you so much, Morgan. Any other questions? I don't see anything else in the chat. Is there anyone on the line that would like to speak up?
Yes, please. My name is Barbara, and I actually learned, I'm a recent Sutter patient, and I learned about PFACs because I got the email announcing this talk. And I'm very happy I did, and I did apply to be a member. My question is, well, first, what you have accomplished in just 18 months is jaw-dropping. And I'm wondering what you see over the horizon in the next, like, even 3 to 5 years out. Where do you hope this program will be?
Great question.
I'll take that.
I know Roberta has an answer.
You know, it's fun because Morgan and I work so well together, and we sit there sometimes and write numbers on the board, how many patient family advisors, and then we kind of check ourselves. What I really hope to see in our future, like 2 to 3 years, I'm not even going 3 to 5, disease-specific groups. Really, where can we get more involved with research and development? How can we tie in the feedback from our patients to improving communication around disease management, particularly diabetes? We've got some really strong work in diabetes, and I think there's great potential here for helping to improve the community. We are just now starting to get into some work at a national level with Yale, and I'll let Morgan say some more about that in a minute. But I think branching out and getting our advisors into even legislation, moving things forward. And that's why the platform of development of our advisors is so important. And we really have to start that curriculum development with Libby's tools on competencies, but then start teaching them more of the awareness of the complexity of healthcare and how their voice can be a part of raising and making decisions and changes. Morgan, other things to add?
Well, I have to quote Roberta Mori, that one day we won't be able to start a meeting because there's not a patient in the room. So that's kind of our vision as well, is that patient family advisors are integrated into more and more of our work. So that's part of it, is just the number of projects, the variety, just growing. And then as well, we really want our advisors to be, those who are interested, not everyone's interested, to be involved in more national efforts, to see what's going on around the country and bring back best practices to Sutter. So being more connected as a system, so that we're not so many different hospitals spread out, but being more connected that way, and then also being connected to national efforts.
Well, thank you, Morgan.
This is Nancy. I don't know if you can hear me.
Yes.
Okay. I just wanted to find out, I believe I'm connected with the council at Memorial Hospital in Modesto, but to my knowledge, we don't have regular meetings. Do the councils have regular meetings?
Do you want?
Go ahead, Morgan.
They do. Modesto hasn't started yet, though.
Okay, all right. So I'm just sitting on the sidelines.
You're just ahead of the game, Nancy. Yes, they are still in the recruitment phase, and they will soon be getting their council up and running on a regular basis.
Okay. If there's any,
they are in that collaborative 3 that Roberta and Morgan referred to at the top of the presentation. So I want to, as we get up to the top of the hour, thank everybody for joining us, but I also want to create a bridge. The next workshop next month will be our opportunity, PFCC Partners opportunity, to present the expanded and newly revamped Patient Family Advisor Network. And I think it's a nice segue from where Morgan and Roberta would like to see their advisors joining on the national conversation and development of the advisory community on that level. We at PFCC Partners seek to be a connector in that regard, and so to do that, we've established the Patient Family Advisory Network, which has been in existence for a couple of years now, but is getting a nice boost. We have many of the Sutter Health advisors included in the advisory network, and the purpose of the PFAN network is threefold. One is to create a sense of community. That's where we created the core competencies, so it's really a community of advisors for advisors. The second area is to create an opportunity for skills exchange, so that our more seasoned advisors might be able to help our newer advisors to the role to understand the opportunities and the value that they have and that they can bring to their organizations. And then finally, we have the opportunity to create engagement opportunities for advisors to state, local, regional, national research projects, all kinds of projects. And I have to say, we used to get that request maybe 2 or 3 times a month, and now we're getting over a dozen, or well, over half a dozen a week. And so we're constantly doing that matchmaking for advisors. And it is a nice way for advisors at your organizations to promote your organization a bit, take part in the national conversation so that we can all learn how to do this work really, really effectively. So I would invite you that if you have advisors who would be interested in joining the PFAN network, that you log in next month for a little bit more information. Feel free to contact us as well. Lots of good things going on there. I will say, with the caveat of, we always encourage our advisors within the network to commit first locally. We know all change happens locally, so we don't want to draw anybody's energy away from their local PFAC, but we do want to augment that with further skills and opportunities. So with that, I'm going to say thank you again to Roberta and Morgan for sharing so transparently your journey, and it is mind-boggling what you've been able to accomplish in such a short time. And I would say that as an observer, maybe an intimate observer to the process with you guys, again, the amount of structure you've been able to put into the infrastructure that makes sense within your organization, and at the same time maintain that high-touch relationship approach, I think that's been just such a key to your success. So all the best on your continued journey, and to all of those of you listening in, I'm sure that you've gleaned some pearls from the presentation today, and I would encourage you to be in touch with Roberta and Morgan, and as well with us here at PFCC Partners. So have a wonderful afternoon, everybody, and a great weekend, and we'll talk with you soon.
Thank you.
Thank you.
Thank you, Morgan. Thank you, Roberta.
Thank you.